Welcome to episode 99 of Dermatology Weekly. I'm MDedge editor Elizabeth Meshkati. Coming up in the peer-to-peer portion of the program, we have the resident takeover with Dr. Daniel Mazori, who will be talking with Dr. Sophie Greenberg about the role of diet in acne, psoriasis, and atopic dermatitis. As always, the peer-to-peer portion of the show will be after the news. In the news this week, we have two stories highlighting some gaps in different areas of dermatology, caring for psoriasis in reproductive age women and in acne guidelines, both based on presentations at the most recent annual Congress of the European Academy of Dermatology and Venereology. In the first story, Dr. Jenny Moresi, a dermatologist at the University of California, San Francisco, described the results of an international survey of dermatologists who were asked about caring for women of reproductive age who had psoriasis. Their answers highlighted some of the challenges dermatologists have in engaging patients in family planning counseling and reproductive health care as part of risk assessments for psoriasis, according to Dr. Moresi. The results are based on responses to a 20-minute online survey on psoriasis and pregnancy completed by 167 dermatologists in the U.S., Germany, and United Kingdom. She and her co-investigators found the following. 47% of respondents considered their knowledge of the impact of psoriasis on women's reproductive health to be suboptimal. This knowledge gap was the most common among American dermatologists at 59%. It was the least common among German practitioners at 27%. 50% of dermatologists rated themselves as having suboptimal skills in discussing contraceptive methods with this group of patients. 48% of the respondents overall, and 59% of the American dermatologists, indicated they prefer to leave pregnancy-related discussions to OBGYNs. 55% of dermatologists had only limited knowledge of the safety data and indications for prescribing biologic therapies before, during, and after pregnancy, and they gave themselves an average score of 58 out of 100 in terms of their confidence in prescribing biologics during pregnancy. That's compared with 74 out of 100 when prescribing before or after pregnancy. Dr. Moresi said the survey findings in these three countries make a strong case for future interventions designed to help dermatologists appreciate the value of shared decision-making and develop the requisite patient engagement skills. In the second story, an international panel of acne experts has identified major gaps in current clinical practice acne management guidelines. At the meeting, Dr. Alison Layton, a dermatologist at Hull York Medical School, Heslington, England, presented the findings of the Personalizing Acne Consensus of Experts, or PACE panel. Most of the 13 dermatologists on the panel were co-authors of current U.S., European, or Canadian acne guidelines. The panel identified two key unmet needs in acne care. One, the dearth of guidance on how to implement patient-centered management in clinical practice. Two, the absence of high-quality evidence on how best to handle long-term maintenance therapy, when to initiate it, the best regimens, and when to escalate, switch, or de-escalate it, according to Dr. Layton. The challenge with acne guidelines, she said, is that they mainly focus on facial acne, and they're informed by randomized controlled trials conducted over a relatively short period of time. Because acne is a chronic disease, this results in a lack of clarity on multiple issues such as truncal acne, treatment escalation and de-escalation, maintenance therapy, and longitudinal management. The panel also highlighted strong points of current guidelines, including the high-quality evidence-based recommendations on initial treatment of facial acne. However, a major weakness of existing guidelines is reflected in the fact that well over 40% of patients relapse after treatment, Dr. Layton pointed out. Among the panelists, there was strong consensus that acne management in certain patient subgroups requires special attention. Those groups include patients with darker skin phototypes, heavy exercisers, transgender patients, pregnant or breastfeeding women, patients with psychiatric issues, and children under age 10. A link to the full story can be found in the show notes. And that's it for the news. Coming up, Resident Takeover with Dr. Daniel Mazori and Dr. Sophie Greenberg. Welcome back to Dermatology Weekly. It's time now for the Resident Roundup. Please welcome Dr. Daniel Mazori.
Today I'm speaking with Dr. Sophie Greenberg about the role of diet in three common skin conditions: acne, psoriasis, and atopic dermatitis. Dr. Greenberg is a dermatology resident at Columbia University Medical Center in New York City. Thank you for joining me today, Dr. Greenberg.
Thank you so much for having me.
Let's start with acne. What are some foods that are associated with acne?
So studies are showing an increasing association between high glycemic diet, meaning foods that spike your blood sugar, and acne. This includes a diet high in milk, sugary beverages, and foods and fatty foods. There's also a lot of studies supporting an association between skim milk consumption or whey protein supplementation with acne flares.
That's interesting. Do you know what the sort of biological mechanism is for these associations?
There's some scientific data to show it's mainly through the insulin-like growth factor 1 pathway, which promotes androgen synthesis, such as testosterones, and increases their bioavailability due to decreased synthesis of the sex hormone binding globulin. This growth factor also stimulates the downstream target called mammalian target of rapamycin, or mTOR, which causes oxidative stress and inflammation. And as we know, acne is multifactorial, but can be exacerbated by hormones and inflammation.
Do you know sort of how robust the data is showing this association? Are there any limitations to these data on acne and diet?
Yes, and that's a good question because, as you know, a lot of patients will come to you asking, is there something that I'm eating that's impacting my skin? And it's really good to be able to be confident in what you tell patients. So the dietary associations have been mainly prospective cohort studies, which do have biases in terms of what people are remembering, or if they know they're being studied, are they changing their eating habits? And it doesn't take into account other associations between diet and other aspects of a person's health that might be contributing to their acne.
So that's acne. In terms of psoriasis, can you speak a little bit about the relationship between psoriasis and weight?
Yes, so the literature is consistent in showing association between obesity and psoriasis. We know that weight gain can cause flares of pre-existing psoriasis. So encouraging your patients to adhere to a healthy diet is an important factor in managing obesity, along with physical activity, and in some cases, medication or bariatric surgery.
Are there any diets that could benefit a patient with psoriasis specifically?
Yes, so there is a correlation between the Mediterranean diet and psoriasis improvement. It has been shown that patients adhering to the Mediterranean diet may have a slowed progression of psoriasis. And it is worth mentioning that patients with psoriasis do have increased risk of comorbidities like heart disease, metabolic syndrome, hyperlipidemia, fatty liver. So it's important not only for improvement of their skin, but their overall health.
The last disease that I wanted to ask you about is atopic dermatitis. And I think, this one is particularly interesting and noteworthy just because among all my patients, I think the ones with atopic dermatitis tend to ask the most about the role of diet in their disease. Certainly patients with psoriasis and acne do as well. But I think with atopic dermatitis, it's just so much more, especially because a lot of those patients are children. And I think it's a question that parents are very curious about. So with that in mind, what role does diet play in atopic dermatitis?
Yeah, I found that too, that patients are always concerned and asking about diet. A small minority of patients can experience flares of their atopic dermatitis due to food allergies. And this is usually non-IgE mediated allergen exposure. It's notable that patients with atopic dermatitis have the atopic march, and they are at higher risk compared to the general population of developing both IgE-mediated food allergies and non-IgE-mediated allergies. But I do think it's important to know that it's really a small minority that their skin disease flares in relationship to their diet. So I usually counsel patients that it's unlikely to be related to diet. And I think it's important to be prudent in considering who you refer to an allergist to have a workup for food allergies. And this might be patients with persistent severe atopic dermatitis, or some parents do notice when their kids eat a certain food, their skin does flare.
So, by way of summary, if you were going to be counseling a patient with acne or psoriasis or atopic dermatitis, what would you tell each one of them when it comes to their diet?
That's a great question. So I always like to remain scientific and evidence-based in my approach. I usually encourage patients to have a healthy diet for their overall health, but if they do have a concern specifically, I will mention to them some of these data related to specific conditions. For acne in particular, I have noticed that some patients do find that certain foods consistently trigger their acne, especially dairy foods. So I'll tell patients, some people find an association between their foods, some people don't. These are what the data show, and you can give it a try if it works for you. But again, emphasize encouraging overall healthy diet, which honestly does go along with all of these data. Same thing for psoriasis. And in these cases, I would also make a point to tell patients a lot of the studies we have are really the tip of the iceberg. And in the future, there will be more studies. There's always new data coming out. And this is what I can offer to you, but things do change. So again, going back to emphasize an overall healthy diet that works for them and their lifestyle. For atopic dermatitis, as you mentioned, a lot of the time parents are very concerned about whether foods are flaring their kids' skin. I would really take the time to listen to see if the parents are noticing a correlation between their kid eating a certain food and their skin flaring. And in that case, I would really consider an allergy referral so that the appropriate experts are involved. But I do emphasize to the parents that for most patients, skin disease does not improve with elimination of diets, and that it's really important for their child to eat a well-balanced diet with a lot of variety unless they have a true allergy.
Thank you so much for that summary and for this information overall. I think it's going to be really helpful to our patients and something that our listeners can hopefully apply in their day-to-day practice. And as we've talked about, the data is growing. And so I'm really excited to see what the future holds in terms of what else we'll learn about skin and diet.
Yeah, me too. There's been so many exciting publications in recent years, and I always look forward to what's coming in the next year, 5 years, or 10 years on this area so that our patients can be really informed and make healthy choices for their skin and for their entire health.
Thank you so much for sharing all that really helpful information. I think that we talked about a lot of discrete points that are really actionable that people will be able to use when it comes to seeing their patients with these conditions. And I'm excited to see what the future on diet and skin holds in terms of, more information that's going to be coming out.
Yeah, thank you. I feel the same way. I think I was inspired to write this article as a starting point, especially for residents interested in learning about some of the science and data that we have so far. But I do think this area is a booming field. Over the past 5 years, we've had so many important studies come out of this, and I look forward to seeing what else we find in the next 5, 10, and 20 years.
Thanks again for joining me. And until next time, this has been Resident Takeover.
That's it for episode 99 of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by Nick Andrews and MDedge executive editor Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.